and I will get started introducing her as people file in. So it is a huge pleasure to introduce Dr. Sheila Crowell, who trained with me at the University of Washington in Seattle, where she received her PhD in child clinical psychology. And she was known as a total star in every realm. As Steve Henshaw always says, she's a triple threat in terms of being just exemplary in her research, teaching, and clinical expertise and excellence. And she was also a really well-loved community member back in graduate school. In her current position at the University of Washington, she directs a research team in which they're conducting innovative research at the intersection between clinical and developmental psychology to discover how psychological struggles emerge and change over the lifespan. And as you'll see today, her work is focused on researching and preventing extreme psychological suffering among vulnerable and misunderstood populations, including those who engage in self-inflicted injury, those who struggle with personality disorders, substance use, stress or trauma, abuse and maltreatment histories, exposure to racism, or who have died by suicide. Currently, her team is conducting a series of funded research projects focused on emotion dysregulation in pregnancy and infant development across early life, self-injurious thoughts and behaviors that occur during pregnancy or shortly after birth, and experiences of racism and discrimination against Black and Latina pregnant people and their effects on their infant, as well as parent and infant sleep in the first year of life as early signs of risk for child ADHD. Dr. Crowell is a practicing psychologist. She also co-founded the Utah Center for Evidence-Based Treatment. She practices fabulously in dialectical behavioral therapy, rumination-focused CBT, and provides parent coaching. And I just want to highlight that she has received quite a lot of awards, and in particular ones I know that folks in this audience will appreciate. She was given the Distinguished Mentor Award for graduate students and postdoctoral scholars, as well as the Outstanding Psychology Faculty Award. And more recently, I'm very envious, she completed a Fulbright fellowship down in New Zealand. On a more personal note, before I give the floor to Sheila, I've always really deeply admired Sheila for who she is, her authenticity, her mix of remarkable precision in terms of understanding complex biology and systems thinking, but always holding that in conjunction with true wisdom and respect for the beauty and nuance of human experience, and her persistent advocacy for those who need it most, even when it's hard, like now. So please join me in welcoming Dr. Crowell.
Well, that's officially the best intro I've ever received. So we're done. It's good. All right. Well, hi. It's so nice to see all of you today. Where to start? I thought I'd start with a check-in because this is a talk. We're going to talk a bit about stress and emotion dysregulation and heart rate. How are you doing? Anyone stressed right now? I don't know, maybe. But like, actually, more seriously, if I know you have food in your hands, so forgive me. Are any of you parents or caregivers? Yeah? Okay, good. Keep your hand up if you're a parent or a caregiver and also stressed. Yeah? All right. So this talk is relevant to you and to all of us right now. So I'm going to use some slides that I've used before and some talking points that I've made before, but the script is really quite new right now because of all the things that we're going through. So I am going to reference perhaps some of your own experiences as we go through this. Quick overview of the talk. So I'm going to start by talking about the biosocial framework that I use in my work. Then talk about some of my work in adolescence, which is where I started. And then move back earlier in the developmental lifespan to pregnancy, early development, and then some of my current and future directions. Okay, so a biosocial theory has guided a lot of my work, as it does for probably many of you. And this is because when we look at outcomes like self-harm or suicide, which are of interest to me, we can look at many of the problems that contribute to death by suicide and see that so many of these have origins in early development. Health problems, financial problems, legal problems, relationship problems. These are things that have early origins. So this is what has contributed to my perspective. So we know that early in development, we have things like heritable risk and in utero exposures, leading to early neurodevelopmental profiles that we can see as early as birth, early temperament and caregiving, interacting with caregiving behaviors, emerging personality that starts to form by adolescence that interacts with things like invalidation and conflict escalation. And then finally, we start to get this sort of stability around mental health struggles, which then affect the next generation. However, all of this, of course, is occurring within this broad context, and we're all feeling a really particular context right now. So I want to highlight that although we're talking about things that are happening at the proximal level, it's not disregarding this broad context. In fact, the broad context is critically important. It's just that this is where a lot of our operations are, a lot of our influence is right at those like micro levels of what people can do and what people have agency over in their own life. So I also think there's a bit of a need for a reframe of the biosocial theory. So this fits with our broader understanding of psychopathology, which is that what we think of as biological vulnerabilities are not necessarily static, and they're not necessarily risk factors, right? They're part of human variability, and human variability creates strength and beauty in our population. Identifying differences is something that we can use to support unique growth trajectories, right? Attention differences, and look at people for who they're going to become with all the full beauty. Caregivers are doing the best they can and are striving to do better. And that's why I wanted to start by checking in with all of you, because one takeaway that people sometimes have from a talk that's about parenting behaviors is like, oh crap, I screwed up my kids. Like, no, that's not the point of this talk, actually. So hopefully I'll emphasize that enough for you all to get that point. And caregivers also live within an invalidating cultural context, right? So caregivers who are working with clinically and in ourselves deserve compassion and skills. And this is where I recently have come to a more hope-based biosocial conceptualization that can guide future work on resilience and empowerment that begins before birth. I know the word resilience has become kind of a tricky word lately. So I looked it up for synonyms and realized that one of the main synonyms for resilience is flexibility. And I'm going to come back to that theme in my talk because a lot of what we're seeing in my work is about rigidity and blunted profiles rather than flexibility. So I started thinking that's kind of the meaning of resilience that I mean here, is the opposite of rigidity. Okay, so within this biosocial research program, there's all of these developing, processes that over time shape our development from infancy to adolescence and beyond. And in this talk, I'm going to talk a fair bit about the parasympathetic nervous system. So I'll get to that. Just like take a quick look though. I had to look all over the internet at the pictures of the parasympathetic nervous system. Most of them just leave out the fact that your uterus is innervated by the parasympathetic nervous system. So this is part of this whole process of what happens intergenerationally beginning in pregnancy. Okay, so I'm going to go through this somewhat quickly. Many of you are familiar or won't actually care in the long run, but we have our sympathetic nervous system, which is our flight, fight, response system, and that facilitates our quick responses to stressors. Some of the studies that I'm not going to talk much about today focus on electrodermal activity, which is part of the sympathetic nervous system. Our parasympathetic nervous system promotes maintenance of the body at rest and facilitates recovery. And respiratory sinus arrhythmia, RSA, or heart rate variability, which I use somewhat interchangeably in my talk, is the ebbing and flowing of heart rate across the respiratory cycle. So low RSA means low flexibility, low variability. Your heart rate is usually high and static, like a soldier marching. And high RSA is depicted in this picture, right? That variability such that when you breathe in, your heart rate speeds up. And then as you exhale, your heart rate slows down. So we're going to talk about this like blunted pattern that I've seen across different age ranges and different groups. A blunted sympathetic nervous system response is a less robust response to stress, which is consistent with impulsivity and sensation seeking. And a blunted parasympathetic response is less regulation over that physiological stress response, less downregulation of the stress response, and tends to correspond with things like poor emotion regulation. Why the vagus nerve, right? Why the parasympathetic nervous system? I think it's worth highlighting that it functions as the major reciprocal pathway between brain and body, that it controls the body's baseline functioning in times of rest and relaxation, which some of us may remember. An essential part of the parasympathetic nervous system, which is responsible for calming our organs after the fight-flight response. And it can be measured via resting and stress-based heart rate. But it's interesting, it's like more interesting than that, right? It's related to the gut-brain axis, to interoceptive awareness. It's one of the few things that we can consciously control and may play a role in how stress becomes biologically embedded, and it can be socially regulated. So it's just a really fascinating biomarker. So I've been thinking more about this as actually a social biotheory. And what I would say I study is how dynamic and modifiable patterns of family interaction can shape child development, can shape the child's biological response patterns, and long-term resilience to psychopathology. Okay, so I'm going to start with some of my earlier work on parent-teen interaction patterns. And some of the guiding questions of our work were things like, are adolescent, these were girls who engage in self-injury, already showing some signs of risk for personality disorders? Are there mother-daughter interaction patterns that may correspond to higher or lower risk? Are there parasympathetic nervous system differences associated with those interaction differences? And using dynamic causal models, can we disentangle whether the mother's behavior is driving changes in the adolescent's behavior and physiology, or is the teen evoking parent behavior and physiology? So to look at this, we coded conflict interactions between mothers and teens. They were really actually quite fun to watch. I learned a lot from my future teen parenting years. So we sort of boiled things down. We coded them second by second. We boiled them down at the utterance level to low aversive, intermediate aversives, or high level aversives. And then we explored differences between teens and mothers based on their group status, control dyads relative to teens engaging in self-injury. So let me walk you through this. We've got teens on the left, moms on the right. And then we've got the percent of time that a teen engaged in high-level aversive verbal behaviors. They were attached to physio equipment, so they couldn't actually do the highest level, which was physical aggression, thankfully. Then we have intermediate level aversives and low-level aversives. So you can see it was a sort of moderate level conflict on average across the group. In the control dyads, we had only 12% at the high level, and then the rest at intermediate and low. And then we have moms. So now we're gonna look at the conditional probabilities from one side to the other. So if a mother engaged in a low level aversive, what did the teen do? 47% of the time they matched. At an intermediate level, the teen matched 31% of the time. And at the high level, 28% of the time, the teen de-escalated to the intermediate level of aversiveness. In control dyads, the mom de-escalated the most, like consistently across all different levels of aversiveness. So they seem to be co-regulating by consistently reducing conflict. When we looked at the same process in the dyads with the self-injuring teen, slightly higher on the high-level aversives, but mostly intermediate and a few low-level aversives. For the moms, similar pattern. And what we see is that when the mom did a nice low-level friendly behavior, the teen most often escalated. And when the mother was at the intermediate level, she matched. And at the high level, de-escalated. The other way, what does the mom do? We see matching at the low level, matching again at the intermediate level, and de-escalating from the high level. So what we have here is a pattern where mother's most common strategy is to match at low and intermediate level aversives. And teens and mothers only de-escalated conflict when their partner escalated to the highest level. This is a common pattern that we see in a lot of different groups, which is essentially in order to get de-escalation, you have to escalate to the highest level. So it's reinforced. We then added a comparison group of depressed teens and used the same conflict protocol and scoring system. And what we are looking at here is just across the 10 minutes, what are the patterns across these three groups? So here we see that both depressed and self-injuring adolescents, I should say that's the graph is minutes along the x-axis, and on the y-axis we have aversiveness during conflict. So here we see both depressed and self-injuring adolescents show this increase in aversiveness over the 10 minutes. And control teens start to de-escalate after about 5 minutes. So that seems to be showing that same pattern of as the mother is co-regulating, de-escalating the conversation, they begin to eventually de-escalate. On the mother's side, we see that only the mothers of the self-injuring teens showed this increasing pattern where there's about 5 minutes, and we could see it pretty visibly in the room as we were watching the families interact, that for about 5 minutes, everyone could kind of hold it together. But as that second half of the interaction carried on longer, is where things started to get a little more intense. So then we moved on to a different type of statistical modeling using dynamic causal models. And this was to help us understand, does mother behavior drive adolescent behavior and physiology? That would fit with like a daughters are attuned or sensitive type of theory? Or does daughter behavior drive the mother's behavior and physiology? That would be a daughters are evocative theory. And are there differences across the groups? So what we saw is that in dyads with a self-injuring teen, the mother behavior was driving the teen's both physiological and behavioral response patterns. In dyads with a depressed teen, the mother behavior drove teen behavior, but not her physiology. And in typical control dyads, the mother's behavior did not drive either the teen's behavior or physiology. So across all groups, we did not see the opposite. Teen behavior did not have a driving effect on mother's behavior and physiology. And these findings are more consistent with sensitivity theories of development rather than an evocative process, at least in a lab-based conflict task. So what does this mean for all of us? All of these teenagers, regardless of their diagnostic risk, were engaging in pretty aversive behaviors during conflict. I love it, right? Teens are my favorite, so both clinically and in my own children's development. So for parents, not matching or escalating the conflict may serve a co-regulation function. And de-escalating conflict might lead to some biological benefits via the parasympathetic nervous system. I'd like to say, though, that it's probably more than just validation skills that are needed, because parent self-regulation supports co-regulation. So a lot of times parents come in to work with us and their goal is, okay, tell me what I need to do to fix this, without like stopping and being like, no, actually you deserve some support too. Okay, so you might be like, whoa, we just jumped to pregnancy. What happened here? But a lot of us, I think, have had that same experience of being like, wait a second, what if we had started sooner? What if like the support was given to the parents much sooner? And it really is, early development is a missed opportunity for detection of risk and prevention. We know that treatment delays for social and emotional difficulties can increase risk for more complex forms of psychopathology, and that this delay is a problem because early intervention during periods of high brain plasticity can be quite effective. And 1 in 5 children ages 1 to 7 already meet criteria for a diagnosis, as you all know well here. So this is an opportunity for early intervention. So a question we've had is, can we identify risk for future mental health struggles beginning during pregnancy, even before birth, or even within the first hours after birth? And I also went into this line of work so that I could put cute baby pictures on my slides. So some of the guiding questions that we had were, what are the struggles and unique stressors that are associated with being emotionally dysregulated and pregnant? How do we understand self-injurious thoughts and behaviors among pregnant participants? This is an area that is seriously neglected, and we've learned a lot about how to ask and talk to pregnant people about self-harm and suicide. Their doctors don't do it. So just side note that this is missed in their prenatal appointments. And we had a question about, does emotion dysregulation in pregnancy correspond to differences in parasympathetic nervous system functioning? And what about the newborn and their neurobehavioral outcomes? So I'm going to kind of go through this first study quickly. Mostly, we wanted to characterize the sample and understand them in the context of self-injurious thoughts and behaviors, and then assess whether emotion dysregulation affects mother's RSA responsivity to the baby cry stressor. So just a few key points about this. We oversampled for high emotion dysregulation. So our mean score was 80 on the difficulties in emotion regulation scale, which is about 15 to 20 points higher than community averages. We had 27.5%. They were not recruited for self-injurious thoughts and behaviors. They were recruited for emotion dysregulation, but 27% who had SIPBs. And then we also had fairly high levels of both depression and anxiety, as you would expect. Okay, so respiratory sinus arrhythmia. We're back to the parasympathetic nervous system. This is watching a baby cry, and it's not like the most stressful baby cry video, but it's, you know, it's a whole minute of a baby crying. It's a little rough. We have mothers with high difficulty in emotion regulation and mothers who were low on the DIRS. And again, well, I'll talk you through this. So what we saw is the mothers with higher emotion dysregulation showed a more blunted RSA response to the infant cry stressor. So it's not a significant baseline difference, but a slope difference. So this response to the cry was not as evocative physiologically for these mothers. Oh, I'm going forward. I just did not get a chance to say anything about the orange line, which is like that more response, that stronger response is what we saw in the more, in the lower DIRS group. So then what about the babies? In this study, we were curious about neurobehavioral markers of emotion dysregulation among newborns using the NICU Network Neurobehavioral Scale, or the ENS. And we wanted to investigate whether maternal emotion dysregulation and RSA during pregnancy would associate with ENS scores. So what is the ENS? Basically, you take a baby right after birth and you do things like you look at how it soothes, how it tracks a moving object, things like you brush its foot on a table and it does a little stepping reflex, which is so cool to see. And you can get a sense of things like, how well is this baby soothing, regulating, how does it do on grasp reflex, rooting reflex, all of those things. So we took a bunch of different factor scores and we looked at the baby's arousal and attention. Arousal is things like motor agitation, irritability, physiological instability. And then ENS attention is things like engagement with the experimenter, with auditory and visual cues like that red ball that you saw, and coordinated visual tracking. So what we found is that for mothers who are more dysregulated, they showed babies with already lower arousal, and this was within the first usually 48 hours after birth. and lower attention. So infants of dysregulated mothers show, again, a blunted neurobehavioral profile within the first hours after birth. And then just a few other things for us to all be thinking about. So emotion dysregulation in SITBs during pregnancy are more common than reported in the literature. They often aren't asked in any of our studies. And one of the things we've learned is that self-report measures are better at getting at this than interviews because there's a lot of stigma around self-injury. So when we recruited mothers specifically for their self-injurious thoughts and behaviors, then the interviews went fine, they went really well. But when you're asking moms in a different study where that's not the purpose, self-report measures work a lot better. I think this is gonna increase because we have a lot of complex and restrictive laws all around the country affecting reproductive health care. I think we're gonna see more moms who are at risk, more pregnant people who are struggling. Greater third trimester emotion dysregulation affects both mothers and newborns. So shifting emotion dysregulation through intervention could have benefits across both generations. And these more dysregulated mothers may have infants who look easier at birth because of that lower attention, lower arousal, but those infants may also be less engaged and less engaging, so less likely to demand the attention and attunement that they might benefit from. So targeting emotion dysregulation could help. Okay, so where does this go from here in infancy and early development? All right, so a guiding question here was, does maternal pre and postnatal dysregulation affect infant regulation during the still phase protocol? The still phase protocol, this is a person who did this for a class assignment to show a sort of modern version of the still phase protocol where she looks at her phone. In our typical experiments, we have the mom maintain a still face at the baby. Okay, so we'll just look at a little example. Hear it. So she's just playing. So this is the play phase of the still phase. The baby's loving it. And then this is the still phase. So we have the moms usually just stare deadpan at their child, which babies don't like. And you can see already the baby's starting to do little movements of irritability and annoyance. Now, I'm going to do a cute little smile. Okay. I'm going to make some noises. Stress sneeze. That is actually a stress sign. So babies kind of start to lose regulation first by all these movements. And many babies just lose it. And now we have the reunion phase of the still phase protocol. So in the reunion, we can see how quickly does the baby regulate once the mom is paying attention. Cool. All right, so we looked at the baby's physiology during the still phase protocol. So first during play, then during the stressor, which is the still phase, and then during reunion. And we looked at this moderated by the difficulties in emotion regulation scale, so low and high emotion dysregulation. And what we saw is that the infants of more dysregulated mothers again showed a blunted RSA profile in response to the still phase paradigm. Whereas the infants of less dysregulated mothers showed this more flexible, although more intense response with a significant decline and then recovery. So a question we had is, does the ends also relate to later outcomes like at toddlerhood? So 18 months is about as far out as we could go with NIH funding. And we looked at the infant and toddler social emotional assessment, or the ITSE. So don't look at that. I'm just putting it up here. I know it's like so overwhelming when people do that in talks. The question we had was ENDS profiles, do they associate with 18-month dysregulation on the ITSE? And I'll have you focus in a minute on two profiles. Profile 2, which is low arousal and high lethargy. So a kind of more blunted type profile. And profile 3, which is high arousal and high stress. So this is a more stressed or aroused profile. Okay, now we can sort of look. Whew, that's got better, huh? Okay, so here, what we see is these babies in profile 2, they had a more blunted pattern at birth, and they show a pathway from maternal emotion dysregulation to infant negative affect to toddler behavior problems on the ITSE across all 3 domains: toddler dysregulation, toddler internalizing, and toddler externalizing. In this more intense, high stress babies, we did see a direct effect from maternal emotion dysregulation to toddler emotion dysregulation at 18 months, but we didn't see the whole profile of internalizing, externalizing, and dysregulation. So we kind of see, like, from birth onward, these are just a little bit more intense and dysregulated type kids. So looking at all of this, infants whose mothers are more dysregulated aren't as responsive on the still face protocol. An adaptive response to stress actually is to have a robust response and then a quick return to baseline. So the way I talk to people about this clinically is essentially we want to be emotional athletes. Emotionally, it's good to have strong responses, but also to be able to recover quickly. And physiologically, that's true as well. And then using the ENDS neurobehavioral assessment, it's possible to see early signs of dysregulated attention and arousal, even in those first few hours after birth. And infant temperament interacts with maternal emotion dysregulation to predict out to toddler dysregulation at 18 months. So supporting parents to change these patterns, even without intervening directly with the child, could make quite a difference. It's a direction that we hope to get. We're sitting awaiting notice of award, like probably many of you, to actually target during pregnancy emotion regulation skills. Okay, so where are we going from here? I've been talking a little faster than I intended, so we are probably going to have time for questions. That's good. I'll tell you a little bit about what's ongoing right now. So working with Maureen Zalewski, also at the University of Oregon, to look in more detail at self-injurious thoughts and behaviors among pregnant women. So I'd be really happy to talk about that. And what we ended up doing is recruiting 3 groups of participants, not because we wanted to look at group differences, but because we wanted to have a full range on self-harm and suicidality. And so we had women who had both past and pregnancy SITBs, and then participants with past SITBs only, and then those with high emotion dysregulation but no SITBs, which was in fact our hardest group to recruit. And then we looked, this is with a American Foundation for Suicide Prevention Award, so we really could only go out to about 4 months postpartum with that, and we have just wrapped up data collection, so we're working on our first few papers from this study, which is really exciting. Hopefully more research to come in this area. And then the other project we have going on at this moment is looking at sleep predicting early attention and behavior problems. And in this study, we have a birthing parent and their partner, which is so exciting because partners are often neglected in research. And this is our first time to really have a triadic study, and the baby. And we've got, for this study, the birthing parent and the partner both wearing Fitbits. starting in the second trimester of pregnancy and continuing until 12 months postpartum. And then the baby's wearing something called the Outlet Dream Sock, which people love. The pregnant people and their partners are very excited for this. It's like a little, sleep monitor that you put on the baby's foot, which is pretty cool. It's their own little baby Fitbit. And the goal of this study is to look at how attention and behavior dysregulation emerge. So we all know if we're not sleeping particularly well, we're more emotionally, behaviorally, and attention dysregulated. And we know that's true for teens and for school-age children. And no one ever thought really to look, what about right in that first year of life when the baby is learning the skill of sleep and the parents are figuring out how to sleep all over again. So it's a fun study. We've got about our first 30 or 40 participants in now, and we're hoping to have cool results soon. And then the GLOW study. So in this study, I love this logo so much, generational learning to optimize wellness. And the question is, how do traumas and the chronic weathering effects of racism affect mothers and their fetuses? So some of the cool things that we're doing from second to third trimester is looking at birth stories, fetal heart rate variability, and the ENDS exam. And we did a pilot study before this and looked at people's stories of their experiences of racism and discrimination. And these are some of the categories that we coded. Nico, who's there, coded. And things that on the purple bubble, we have our racist events, things like threats, stereotyping, assault, workplace discrimination. In the coping category, people talked about social support and coping ahead for difficult situations. And in the responses, we had a bunch of really invalidating responses and support and validation. The first version of this figure that Nico sent to me had all of the different forms of invalidation or unkindness that people received when they tried to talk about their racist experiences. And I was like, okay, so there's one bubble that looks the biggest, support and validation, and then there's all these smaller bubbles, but all of them were unkind. So she remade the figure to really show that it is actually more common for people to receive unhelpful comments in response to sharing their experiences of discrimination. So just a few of the quotes in each of these three bubbles. In the racist events category, the boss said, "I'm glad I took a chance on you. Your previous employer told me not to hire the Latina." And this actual previous employer was mostly a check signer, didn't even really interact with her. He said that if we had children, they would be ugly because they would be Mexican, and make comments about my hair's thickness and color, especially on my arms. They made me feel down about my appearance. In the coping category, I had a lot of social support from coworkers after the altercation. If someone said something rude to me any day, they would get involved and support me. I felt better knowing my coworkers have my back. And in the cope ahead category, which is especially relevant for pregnant participants, I just think preparing my future children for this possibility, preparing myself for the circumstances happening. And in responses for others, in the invalidation category, an example is, my family did not understand why I was that affected by the experience. And in the validation support category, my family said supportive things like, "It's okay, let's just do what they ask, we'll be okay, you've done nothing wrong." So all of this is happening in that context around the biosocial processes happening for these pregnant women. And what we're looking at now is whether there are effects on the fetus that we can measure through fetal heart rate variability. And we've partnered with a company called Nuvo that has this belt that measures the fetus's heart rate variability. So more to come on that. Okay, so just a few final thoughts to wrap up, and then we'll have plenty of time to chat, I hope. If you, like me, are apparent and distressed. Here's some take homes. Practice self-compassion. You are doing the best that you can. Paced breathing slows the heart rate and increases heart rate variability. It does make a difference. You can actually train your heart rate variability. When possible, attend to children and talk to them with authenticity and equality. A lot of times we think about validation as just like pure approval, but really what kids respond to is genuineness and treating them like they already have the capabilities that you know they're going to develop. And whenever possible, de-escalate conflict. I want you to just take a quick minute. This is a thing I want us all to think about. Reflect on your own caregivers. Were they perfect? I'm guessing not. Most caregivers aren't. Mine certainly weren't. But was it their imperfections that caused the problems and struggles that you have today? Or maybe did some of the imperfections and flaws of your caregivers lead you to become compassionate and caring and the type of person who would work in a field devoted to helping others for way less pay than all of you could deserve with your intelligence and capabilities? It's maybe a problem of our developmental psychopathology literature that so much of the work is oversimplified to bad thing causes bad outcome. And we know that that's not true. And yet we're really struggling, I think, as a field to figure out how is that more nuanced, right? What is the way in which actually sometimes the hardest things we go through, sometimes our darkest moments, sometimes our moments where we're struggling with our own mental health are the things that make us fully who we are and give us our strengths and unique capabilities. And I have been looking for the places where that's really represented in our literature, and it's not. There's just not a lot of good storytelling around this, and it doesn't lend itself well to a simple laboratory design, but we've got to figure this out. So this is my drum that I'm beating. We've got to figure this out. I know a lot of us are doing this clinically, but it's not super well represented in the research literature. So thank you all for listening to me ramble on, and I have many people who I also am grateful to.
Thank you, Sheila, for that kind of life course conversation and in context. Summer, I see you have a question.
Okay, thank you. So, I can talk loudly. So for the, I think I understood that for the adolescent dyad work, that the mother's physiology did not seem to respond to the child's.
Yes.
Yes.
Yeah.
Which feels a little surprising as a mother, but but I think that happens in infancy, right? We have evidence that mothers, I mean, even like the experiment with the baby crying, that we would expect mothers' physiology to change in response to their infants.
Mm-hmm.
So my question is, do we have data on when that shift occurs? Is that like an evolutionary shift to help prepare us to launch our children? Or when would we expect those patterns potentially to shift?
Yeah, that's a great question. So with that particular adolescent study, what we were looking at is these dynamic systems models that would see whether the immediate preceding behavior or physiological response was followed by a behavior or physiological response on the part of the parent, and not sort of the overall, like across the 10 minutes, how was their physiology, which I don't have those graphs right with me, but I do think that their physiology sort of gradually was affected, just not in that like driven by the thing that happened right before. So I'm going to have to think about that piece a little more in this context. And also, of course, It was a very specific type of design of like fight about something that was of moderate, the IRB capped us for good reason at moderate levels of conflict. And so we didn't see the types of things that as DBT therapists, we hear like the parent calling for skills coaching as they're screaming in the background. Like we didn't see quite that level in there. So I think there's probably still contexts and circumstances in which we would see that physiological response still happening. And I love the working theory of like things do start to change as we prepare our kids to launch. So I'd need to think about that more. I'm launching two right now, one a sophomore in college and one who's 18 and graduating. And yeah, it's a big deal, the launch phase.
Thank you.
Yeah, great question.
Other questions?
While
Any
you're
from the interwebs?
thinking about questions, I'll just say also, I mentioned I do dialectical behavior therapy. I do a lot of parent coaching. And I also, as Nikki mentioned, do rumination focused CBT. So I could also talk about rumination or just other random things that you want to talk about in this field.
Good question about that. So like many of us, we started working with older folks or adolescents, et cetera, and you start to kind of creep back in the developmental life course, trying to target these things where we can do a bigger impact earlier. And yet I did wonder how much you think about these things when you're working with adolescent or young adult clients. Are you hearkening back and trying to understand their caregiver relationship, or is it just part of you understanding the etiology of the development of their dysregulation? Can you speak to that for a minute and how you apply that clinically?
Mm-hmm. Yeah, that's fun. So I can't help myself thinking about both directions. So I do like to get a bit of the developmental story. I had a teen who just really like had a really difficult struggle with attachment with the caregiver. And it was like probably halfway through the therapy that she mentioned that her mom had been a contestant on The Biggest Loser and had been actually like away from the home for like 6 months of her infancy. And just like, oh, that's a really interesting and unique stressor to have that separation during that critical period of time. So I do like to think back, but then also teens are right on the cusp of becoming parents themselves often. And that was my work on my Fulbright was in New Zealand, teaching some DBT skills in a teen parent unit. So, kind of sad that I came back from New Zealand, but let me tell you, they have these schools where the teen parents, instead of sort of having to figure it out on their own or through packets, which every teenager can agree are the worst, they can actually go to these teen parent schools where they're given a lot of social emotional skills and educational skills that really meet the teens where they're at. And the babies are right next door. So they can also go and interact with their baby as needed, and the baby can be brought over to the school. So in that context, teaching DBT skills was really fun. And there's been a lot of studies that have come out of DBT not working in schools. And so that was kind of interesting. I went in being a little hesitant and did mostly kind of qualitative stuff that we're still working on coding. And students particularly dislike learning mindfulness in schools, and for good reason, right? Like being in the present moment in a place where you're unhappy isn't necessarily like, I can see why that doesn't work a lot of the time. But the teens came back and the thing they said was that mindfulness was the most helpful of all the things that I taught. So when you're working with teens, you're also beginning to shift dynamics going forward, which is cool. And I think a lot of that compassion toward parents work would get better if people remembered that parents were just kids not that long ago.
Hello. We have a question. I'm curious if there are studies that look at emotional regulation in family structures that are communal or more multi-generational versus dyadic.
Yeah. I do not know well enough to answer that question. But what I can say is that I do think that the family structure that is typical in the US is not particularly conducive for emotion regulation because we don't have all the support that we need. And just from my own experience and from talking to a lot of friends going through this stage over the past few decades, people are like, where is my community? You know, it's 4 a.m. and they are trying to soothe their baby back to sleep. And if it's just you and another person, it really is hard to get through that. So I will try and like dig more into that literature. But I don't know that there's a huge cross-cultural literature or even sort of different cultures within the US and emotion dysregulation and pregnancy and postpartum. So whoever you are, good idea. You should definitely do that.
From the audience? One thing I just want to highlight, because I don't know that it came through, is this blend of work, knowing the path that Sheila's taken, like the deep understanding. She made it sound so simple and light touch around the psychobiology, but she actually has incredible expertise in that space, and bringing that into this other world, you know, being trained by Marshall Linehan at UW in DBT and having such a strong focus on emotion regulation and coping and therapies. There wasn't so much of that bridge. And so that's like a real nice pushing forward, but also putting in the intergenerational piece, like bridging these might kind of make sense the way she presented it, but really it's an anomaly to take these multiple circles and put them in a Venn diagram and try to understand this from a more systems, multi-level, from biology across generations framework, both in terms of the etiology as well as, you know, how we tackle this when we're working in community or in individual therapy. So I just wanted to highlight that's a really unique strength that you made sound really simple and kind of obvious, but was not extant in the literature before Sheila and her colleagues started tackling this. And then also just to really highlight how important it is that a lot of work in this space is not addressing racism and contextual factors, gender identity, and other things that are harming and making increasingly challenging to address dysregulation in context. And it's just been really nice. And I cited some of Sheila's work in my Grand Rounds talk last month because it's been really important and foundational to get that out there in these literature. So I just wanted to call that out and thank you for that work. Please join me in thanking Dr. Crowell for joining us down from Oregon. And if you guys were shy and wanted to ask her a quick question in private, she has a few more minutes down on the floor. Thank you.